The Trial of Psilocybin versus Escitalopram for Depression, published in the New England Journal of Medicine in 2021 by lead author Dr. Robin Carhart-Harris, is a Phase 2, randomized, controlled, double-blind trial that compared the effects of psilocybin with escitalopram, a selective serotonin reuptake inhibitor, on patients with long-standing, moderate to severe major depressive disorder. The study enrolled 59 patients, who were randomly assigned in a 1-to-1 ratio to receive 2 separate doses of 25 milligrams of psilocybin or 2 separate doses of 1 milligram of psilocybin plus 6 weeks of daily oral escitalopram. The primary outcome of the study was the change from baseline in the score on the 16-item quick inventory of depressive symptomatology, self-report, QID-SR16, at week 6. The results showed that the mean changes in the scores from baseline to week 6 were minus 8.0 points in the psilocybin group and minus 6.0 in the escitalopram group, for a between-group difference of 2.0 points, p equals 0.17. The QID-SR16 response occurred in 70% of the patients in the psilocybin group and in 48% of those in the escitalopram group, while QID-SR16 remission occurred in 57% and 28%, respectively. The incidence of adverse events was similar in the two groups, with no serious adverse events observed. Dr. Joshua and Dr. Wiley critiques the article and argues that the power and statistical analyses in the article are for a superiority trial, rather than equivalence, and as a result, the trial is likely underpowered. He suggests that even for a superiority hypothesis, the trial is underpowered, as the power analyses were based on active psilocybin compared to control psilocybin, but the trial actually compares active psilocybin to control psilocybin plus escitalopram. In response to the criticism by Drs. Joshua and Ian Wiley, Dr. Carhart-Harris clarifies that their main hypothesis was focused on measuring patient well-being using the Edinburgh Mental Well-Being Scale, WEMS, which was pre-registered as a secondary outcome. The use of the term equivalent regarding the primary outcome was an error, and they did not intend to formally assess equivalency or power. Due to the unique treatment combinations in the study, assessing statistical power was a challenge. Another critique came from Dr. Ian Jordan, who raises concerns about the results of Carhart-Harris et al.'s trial comparing psilocybin to escitalopram for the treatment of major depressive disorder. He points out that 37% of the patients discontinued their antidepressant medication before entering the trial, and notes that acute withdrawal effects from these medications can last up to 6 weeks and may be confused with symptoms of depression. He also suggests that the trial may have underestimated the antidepressant effect of psilocybin because the washout period for the antidepressant medications may have been too short and because baseline rating scales were completed before medication withdrawal. In response to Dr. Jordan's letter, Dr. Carhart-Harris reanalyzed the data and found that discontinuing relevant psychiatric medication before the trial reduced the difference in efficacy outcomes between the psilocybin and escitalopram groups. The improvement in the psilocybin group was greater when there was no pretrial medication, while the improvement in the escitalopram group was less without pretrial medication. The number of patients in each group was small, so the authors do not offer an explanation for these results but mention that there were better responses to MDMA therapy for post-traumatic disorder when there was no pretrial antidepressant medication to discontinue. Drs. Frederick Hieronymus and Soren D. Ostergaard questioned the feasibility of conducting double-blind trials of psychedelic doses of psilocybin in the Phase 2 trial reported by Carhart-Harris et al. They highlight the fact that 25 milligrams of psilocybin is a potent psychedelic dose and that many participants expressed a preference for psilocybin over escitalopram, which raises the issue of unblinding in the trial. They asked for the author's opinion on the matter and if unblinding did occur, how it should be interpreted given that both the antidepressant and psychedelic effects of psilocybin have rapid onset. They also question if trials involving the psychedelic experience can be conducted in a double-blind fashion if the experience is believed to have a mediating influence on positive outcomes. In response to Hieronymus and Ostergaard, Dr. Carhart-Harris agrees that patient preference for psilocybin therapy likely influenced the results in favor of psilocybin and acknowledges the importance of questioning the integrity of blinding in psychiatric trials. The effectiveness of blinding was not measured in the trial, and if it was ineffective, it is unclear if 225 mg doses of psilocybin had a stronger impact on blinding compared to 10 to 20 mg doses of escitalopram over 43 days. There were more side effects in the escitalopram group, but also more acute subjective effects in the psilocybin group. Dr. Gerhard Grunder and Leah Mertens suggest that the results of Carhart-Harris et al.'s trial may have been influenced by a nocebo effect, where patients who were not in the high-dose, non-placebo, psilocybin group experienced disappointment, and this disappointment influenced the results. They argue that expectation bias by both patients and clinicians is a significant factor in trials involving patients with depression, and therefore a placebo is necessary for comparison with active comparators in future studies on psilocybin treatment. In response to Grunder and Mertens, Carhart-Harris and co-authors agreed that there may have been a nocebo effect in the escitalopram group due to disappointment from participants who did not receive a psychoactive dose of psilocybin. They also suggest that the response to escitalopram in their trial was similar to and possibly faster than in other trials of this SSRI, which could be due to the added psychological support. They also note that patient-rated measures appeared to show more sensitivity to change in the escitalopram group. In conclusion, the Phase 2 trial reported by Carhart-Harris et al. Aimed to compare the efficacy of psilocybin and escitalopram in the treatment of major depression. The results showed that psilocybin was found to be similarly effective as escitalopram in reducing symptoms of depression at 6 weeks. However, the study faced several criticisms, including the validity of the hypothesis, the power of the trial, the potential for expectation bias, the impact of antidepressant withdrawal, and the feasibility of double-blind trials with psychedelic doses. The authors responded to these criticisms by clarifying the hypothesis, reanalyzing the data to account for the impact of antidepressant withdrawal, and acknowledging the potential for expectation bias. Overall, the study provided some initial evidence for the therapeutic potential of psilocybin in the treatment of depression, but further research is needed to fully understand its efficacy and the optimal administration conditions.